Hello, good evening, friends. It's a pleasure inviting you for this yet another MIDAS clinical meeting. Um, we have 4 or 5 cases. Hope that will be interesting. For this clinical meeting, I invite Dr. Manoj Vevhare, Dr. Saurabh Patle, Dr. Gaurav Padia, and Dr. B.S. Gedam. Dr. Gedam has agreed to be chairman because Dr. Prachi expressed her inability to come because of ill health. And it's great also pleasure in inviting the online chairperson, Dr. Mohan Ramchandani from AIG Hyderabad, a very dynamic gastroenterologist who is doing a lot of innovative procedures. And he's been trained here in Nagpur in super specialty. And Dr. Sagar Bothra is a consultant gastroenterologist who started practice recently at Yavatmal. So, welcome to online chairpersons as well as the uh, on inline chairpersons. And without wasting time, I hand over to Mike to the chairpersons. Thank you.
Case is by Dr. Akshay.
Okay. Good evening, everybody. Today I'm going to present a short case of seemingly obvious diagnosis, but on retrospect, we'll present it. So, a 62-year-old female presented to us in June 2020 was already on oral hypoglycemic agents for her diabetes and on aspirin 75 milligrams for coronary artery disease. Compliant to these medicines. Complained of bloating and regurgitation for 1.5 years. There were no alarm features such as recent weight loss or recent worsening of these symptoms, no vomiting or retrosternal pain. Upper GI endoscopy was and did not reveal much alarm symptoms or any sinister signs. Endoscopy, diagnostic endoscopy done for dyspepsia non-responsive to GI. On retroflexion in the diagnostic endoscopy, found that she had a lax LES when the esophageal mucosa was visible with reflection. It's grade 4 lax LES. Other than that, had mild changes of the grade. All mucosa. Than that, there were no remarkable findings in this endoscopy. So we increased her dose of PPI and asked her to follow up. We raised her anti-reflux. It was well after that. Here with lockdown, she not actually. So in 2021, she appeared in our OPD again. And this time, she complained of increasing dysphagia over 6 lockdown. The had actually was more to solids compared to liquids. There was nasal regurgitation and retrosternal pain while swallowing. Denied any recent weight loss or anorexia. It and not see any, not actually pick up any sinus examination. Had not reduced. I was 19. So there was no pallor or lymphatic on diagnosis on examination. Even the systemic exam was unremarkable. So, with the clinical decision of a elderly female, slow onset dysphagia, it was 6 months. Slowly, the dysphagia was progressing. There was no weight loss or anorexia. And prior endoscopy already had showed a small hiatus hernia with lax LES. So, maybe a hiatus hernia is a well known cause of dysphagia in elderly. Sort of possibility in this female, which is very common. So, we went ahead with the high resolution. In this manometry, one can see that the upper high pressure zone is of the esophageal and the lower one delineated with red and white lines is of lower esophagus. One can see that there is no deglutitive relaxation of the LES is not opening, and the swallow begins, and the distal latency of the distal segment is that's a premature contraction. The TI was 8,000, IRP was background of dysphagia. We diagnosed as cardia type jackhammer, and the time barium also corroborated our findings where there was a retention of contrast at 5 minutes, and there was third week episodes. Time barium sort of type 3 gained contractility was trying to overcome good muscle contraction. Thought that oral endoscopic long myotomy would help the patient. Head of OM were surprised both at the G junction when we diagnostic and start of the so try to cross this scope was hardly crossable, lot of resistance, uh, kept on bleeding, liable. We obtained biopsies at 35 centimeters just at the G. Upper esophagus was absolutely there was no large height or could not examine the stomach to see facts. Biopsies revealed adenocarcinoma. It was moderately differentiated, but unfortunately, by the time she had presented and with the CT visit, these already showed filtration of the tumor beyond the muscularis propria of the esophagus, crossed into the intestinal connective tissue. Also, there was loss of interest. Was unresectable. Headed for palliative. Was a typical of a pseudo achalasia. In an elderly female with medium duration of and no weight loss or anorexia, and a prior endoscopy about 1 year ago, minor abnormality, no tribal mucosa or growth, had assumed that the not alarm symptom here itself we assumed could have been caused by something else, and we were also of, I have to say, unlucky to get a positive finding at manometry and a diagnosis of achalasia this patient, but avoided the diagnostic endoscopy, which be done in the evaluation of the achalasia cases before proceeding on to a man. And learned our lesson the hard way that the high resolution manometric receiving, even in case of mechanical obstruction. So to diagnose achalasia, one has to exclude mechanical obstruction and only then proceed to a functional evaluation of the esophageal structure. Then only you can diagnose an achalasia. Mechanical obstruction can cause cardia-like picture. In fact, the 19 dual consensus of esophageal achalasia, the guidelines clearly mention Indian authors in Ghoshal and Dr. Sanjeev Mahadeva from Daya University of Gastroenterology. So these two people and the other authors, and that it increases the process time. The point I'm making here is incidence and prevalence of esophageal malignancies, currently does not support screening strategy. Percent papers about this. So, in a run-of-the-mill case of reflux with LES, male, diabetic, has impaired gastric motility. So, all these patients, if you screen with NPI, then don't know if other people.
I personally feel that the patient had achalasia right from, and achalasia is a malignant condition. Development of malignant after it. I am seeing this because most of the achalasia presenting as pseudo achalasia are with gastric of malignancy rather than the esophageal. The manometry then and now shows, and then there is a gap of years.
One and a
You
half
don't.
year. 1.5 year. June 20 to November 21. 1.5 year.
1.5 years, but then during that time, because of stasis, comes precancerous, as we know that is a precancerous condition. So, I mean, the achalasia could be a basic diagnosis, and malignancy can be superadded. This is the one problem. Achalasia presenting as malignancy presenting as pseudo achalasia is a problem. But I would go rather than the second. Even the manometric abnormalities are showing now also achalasia. We can have an opinion of Dr. Mohan. Mohan is there. He's expert in achalasia. He's formed the guidelines of management of achalasia.
Hello. Ramchandran, you'll have to unmute.
Mohan sir, good evening.
You have to unmute yourself, Mohan.
Oh, hi. First of all, thank you, Dr. Mukewar, for inviting me. This is a fantastic gathering I can see. And the case was equally a very important lesson that a fresh dysphagia in an elderly female should be taken seriously. And before diagnosis of achalasia, one has to see what are the symptoms. The patient has more of dysphagia rather than pain, which is more common in type 3. And I could see the manometry, which has shown compartmentalization of the pressure at lower end. And also we took a lot of reliance on the initial endoscopy, and which was almost 1.5 years back. So still the new things can be developed, and I agree with the question that NBI a proper might have picked up early cancer over there at that time. But we have seen pseudoachalasia. This was lucky that you could see the mucosal. I have done 2 poems in patient who ultimately turned out to be CA pancreas, but the pseudoachalasia was because of paraneoplastic syndrome. There can be also CA lung causing submucosal tumor deposition, and the mucosa is absolutely normal. So that term pseudoachalasia is real pseudoachalasia. When you do an endoscopy, you don't find any mucosal. But once you do EUS, you will see differential thickening of submucosa, or a CT scan, you can see some of the diagnosis. But 2 cases we have done where we could not make tunnel, and once we took the biopsies from the tunnel, it came out to be cancer. Regarding Dr. Mukewar's point that it can be achalasia to begin with and subsequently converted into cancer because it is a pre-malignant condition, that is a very big, very important possibility. But I will say that this patient has adenocarcinoma, which is rare to have in achalasia. It is the squamous cell cancer, which is more common in patients who have long-standing achalasia cardia, because there is no reflux and there is stasis on the squamous mucosa, chronic inflammation, dysbiosis leading to dysplasia, leading to cancer. It is more of squamous cell cancer. So I will keep that possibility as downward. But I will say that it's a cancer which has developed very rapidly within the last 1.5 years. Might have not been there at the initial endoscopy. But as the lesson has been learned that any case who have to be diagnosed as achalasia before planning treatment, one has to do a good endoscopy.
I'd like to make. So I think I had seen this patient. So considering that a year and a half ago, endoscopy is normal, very hard for someone that now the dysphagia malignant. Therefore, the plan was to do manometry. Question is whether NBI would have picked it up. It is possible. Now, this one has adenocarcinoma. NBI really is great for squamous cell cancer. We've been doing ESDs for these early squamous cancers. Barrett's would be a predisposing factor, but not have. Odd that this patient have that very short duration of one. And then the second thing, I think, yeah, I think Dr. Ramchandani also remembered squamous cell cancer, which is Online questions.
No, border can be the disputed area. Rather than calling as a adenocarcinoma of esophagus, why not see a stomach with cardioesophagus?
That could have.
Yeah, because I think it's at G junction. Quite
Yeah.
possibly a gastric cancer
Quite
also.
possible. Thank you. Thank you.
So we move on to the next case. Case of ulcerative colitis by Dr. Shrikant Mukewar.
This is the ulcerative colitis case. Had multiple hospitalization. She's a young girl, 24 years old, a sister of a physician who's working at Vardha. And she had come to us on 13th of April 22, not 20. This is 13th of April 22. That time she had a history of loose motions for about a month. The frequency was 10 to 15 times, small amount mixed with blood and mucus, suggestive of a large bowel diarrhea. She had also crampy pain in the abdomen with motions. Weight loss was a significant feature of 8 kg, and there was only recent onset of fever. So anybody with, I mean, less than 30 days history, one has to always think of infective diarrhea. But when she went outside, she was investigated. That time the hemoglobin was 8.8. As we expect, the WBC count should be more, but they were normal. And the platelet count were reverse thrombocytosis. Renal functions were normal. The LFTs were normal. She had a low albumin and CRP was raised. And the viral markers were. She had a sigmoidoscopy outside, which was more or less suggestive of ulcerative colitis in the form of loss of mucosal vascularity, mucosal erythema, superficial ulcers, but there were no pseudopolypi. And so biopsy also confirmed the diagnosis. So she was treated on the lines of severe acute ulcerative colitis. This was outside with 7 days of IV hydrocortisone. Clinical emission was achieved. She was shifted to oral bisolone 40 milligram and mesalamine and discharge. Within a week, that is on the day 10th of steroid, she had come to us with more than frequency of more than 10 per day. There was obvious blood. She had tachycardia. It was advised colonoscopy because once first she had a sigmoidoscopy, she didn't have a complete examination. And secondly, we wanted to find out about superadded infections, why she is not being. So this time the counts were elevated, the albumin was low, CRP was 45, ESR was raised, but the hemoglobin was probably she had received transfusion. The electrolytes and renal functions were normal. So the first clinical decision that whether this patient has a steroid refractory disease, whether there is a superadded infection, because there was no known case of ulcerative colitis and 1 month history. Should you be thinking about an alternative diagnosis? She was young also. And they were explained that if she has ulcerative colitis, she would need biologics, and you have to think about it and start at the earliest. So normally when the patients, I mean, it takes about 4 to 5 days for the quantiferon gold, C. difficile, CMV infection to be ruled out. So she was put on again hydrocortisone 100 milligram TID, we added azathioprine and mesalamine 2 tablets. The stool CDTA was negative, quantiferon gold was negative, X-ray chest and blood culture, and in fact the CT chest was also done as per the protocol. That was normal. He, in fact, he on the sixth day of hydrocortisone, the frequency reduced to 3. So she was shifted on oral steroids on 18th of April, and relapse of symptoms came after shifting her from IV steroids. Now, here the decision was to give her, because she was absolutely not responding to steroids. So we thought of either giving her infliximab, vedolizumab, or IV cyclosporine or tofacitinib, and a surgery as a last option. Plain, but however, in view of the young unmarried girl, that was the last option in with the potent drugs available. Because of the brother being MD medicine, he wanted to be sure that whether before using biologics, one has to really whether they are required. So she was started on biologics, infliximab biosimilar, azathioprine was continued, steroids tapered. Within 3 days, her stool frequency reduced by day 2 to 3. There was no bleed, and the tachycardia had come for settled. She had received further induction doses on 6th of May, 6th of June, was doing well. Then the problem came that she had hair fall, July 2022. So the question was whether it is disease related, drug related, because she used biologics, was on ASA, he was on 5-ASA. All the three are known to cause, but the hair fall is more often caused by the 5-ASA group. So the algorithm says that you stop 5-ASA and then wait. If the doesn't, then you have to stop ASA. Hospitalized again on 17th December, that is after 8 months, with loose motions 5 to 6 per day, short history. Whenever there is a history of exaggeration of these such symptoms, one has to always think of infection. But statistically, it has been observed that the diarrhea is because of flare of ulcerative colitis than superadded sepsis. The counts were normal, the albumin was still low. This time, he was ready for sigmoidoscopy. So we did her sigmoidoscopy. It had a pattern of severe disease with formation of pseudopolypi. Now you can see that there are pseudopolypi here. So he definitely had ulcerative colitis. That's a sign of pseudopolypi. We taken a biopsies and submitted for pathological examination, histopathological examination, as well as CMV infection, without CMV infection. So then we thought that whether this should be defined as biological failure or superadded viral infection. The management options were to another biologics like vedolizumab, use tofacitinib, and of course colectomy at the end. So this was her chart that you can see that she had tachycardia, she had fever, her hemoglobin on 17 December was 5.4. So she had lots of bleeding. Counts were normal. The CRP was 26. She was started on tofacitinib on 21st December. This being a new drug, we thought that let us try this because there is an evidence of effect of tofacitinib in acute severe colitis in the dose of 10 mg PD. So the biopsies were obtained, which again confirmed the diagnosis of ulcerative colitis. May I request Kamyani to please comment on these biopsies? Kamyani.
Yeah, when we receive a biopsy, usually what happens with detail, how long the patient is diagnosed with ulcerative, that the patient is on steroid resistant ulcerative colitis, or what are the WBC counts at the present when the biopsy has been. We don't get to know all this. So when we receive a biopsy, what we saw here is it's the polypoidal mucosa, as you can see, very inflamed mucosa. On a higher part, we can see the lamina has been with plasma lymphocytes, and there are neutrophils on the surface infiltrating even the superficial epithelial at some places. And then there are glands which are showing region of petipia. And on observing, we started seeing some, along with the inflammatory cells, this is the blood vessels, and the endothelial cells were showing some prominent cells that are enlarged almost 3 to 4 times the normal endothelial cell size. They have started showing some basophilic inclusion. Here you can clearly see an aula inclusion, the basophilic intranuclear inclusion. So, and there are some inclusions even seen in the stromal cells here. So basically, when we saw this inclusion, we are thinking, yeah, there isn't. But what is the picture? We saw this picture resembling ulcerative colitis, but at the same time, we had CMV. We don't know because CMV picture also resemble a picture of ulcerative colitis on microscope. Going back, we came to got the history that she's a known case of ulcerative colitis. And the interesting part is CMV seen in ulcerative colitis, which is steroid resistant, most commonly added CMV.
Yeah.
So for this, we should have a very high index of suspicion pathologists, because sometimes even in first sectioning of lesion, we might not be able to identify. Need a very strong suspicion from the clinical side, requesting for CMV, giving us a history that is a long-standing ulcerative colitis, steroid resistant, and superadded infection has been. Most of the time, we might miss CMV on histopathology. Gold standard, if what is antigen, DNA PCR, and histopathology. The gold standard still remains a document of unequivocal inclusion. So it is very important, sir, to know, get the history as you were showing me. The counts have been high and all this. We get that, we'll be patient about
Yeah.
identifying.
Correct. Thank you. Now we done a DNA PCR tissue, and that was positive. Didn't have the number of copies, but that was reported as positive. So she was already continuing on tofasitinib and started on valganciclovir, and the patient is presently doing well with motion frequency of 1. So now, when we discuss ulcerative colitis, first is when we discuss the severity of the disease. When you have the bowel movements of less than 4, it is defined as mild, 4 to 6 moderate, and more than 6. You may have a normal body temperature in mild, but mild fever in moderate and more than high fever. The tachycardia is usually seen in severe disease. Albumin low, raised DSR, are the weight loss, are the signs of severe colitis. Now, possibly this patient has CMV superadded infection. Presentation of CMV colitis, as was discussed, is usually asymptomatic, and the cases are self-limited in immunocompetent persons. Chronic or lifelong carrier can be there in immunocompromised patient and IBD patient. He said that CMV infection is very common and that gets reactivated because of immunosuppression. 21 to 34%, about 1/3 of the patients with severe acute colitis can have CMV infection. Gets exaggerated by immunosuppression, steroids, IBD, rarely biologics. Majority of the times, it is the steroids and the immunosuppression which exaggerate the disease. Uh, Histology shows the classical ulcer appearance. Tissue CMV PCR more than 250 copies per milligram of the tissue. The lesions of endoscopy of CMV colitis would be more or less similar. There are now 10 to 15 conditions which endoscopically can mimic ulcerative colitis, like Campylobacter colitis, Yersinia enterocolitis, CMV colitis, and NSAID-induced colitis. So, looking at the ulcerations, you cannot totally say that it is ulcerative colitis. So, Ganciclovir is a treatment of choice. For Foscarnet is on alternative drug. Of course, we don't. This was, I think, amongst 4 or 5 cases of CMV colitis we have seen in our practice. But I think we need to have more suspicion when the patient is not responding. There could be many cases. And treatment is given if the patient has severe IBD. CMV need not be treated. Sometimes don't require a change of immunomodulation. The change continued. Treatment for CMV colitis when histology shows a high density of CMV virus, or if the patient has low grade CMV but steroid refractory disease, then also. So our patient satisfied the criteria for treating because he had steroid refractory disease. Now, many of the times when the patient is not responding, we need to find out what are the reasons for non-response, whatever is, whether the diagnosis is correct, whether the compliance with the drug is proper, whether there is superadded infection. C. difficile is one of the common causes we need to rule out. CMV colitis, therapeutic levels of biologics not obtained, formation of antibiologics antibodies, and as such, even with biologics, 30% of the patients they don't respond to. So here in acute severe colitis, the efficacy of biologicals and small molecule, the infliximab scores over vedolizumab and tofacitinib. So there is no head-to-head comparison, but a network meta-analysis supports the use of infliximab. So that was the reason why the infliximab was started. So we had a young patient who had a protracted core CMV infection, real steroid refractory colitis, which responded to tofacitinib. In fact, this is the first patient of severe acute colitis who did not respond to biologics and was given tofacitinib in our practice. So we thought that we'll share the data. Thank you. So it was continued. It was continued. Basically, we use 4 weekly rate. So she was from a very good family. Her brother is a doctor. So that was continued. On infliximab, she had a relapse. 10 milligram BD. Normally, the dose recommended is 10 milligram twice a day.
A very nice presentation of the case and highlighting a very important point in managing cases of steroid refractory disease. One point I wanted to highlight that the patient had started with severe hair fall, and azathioprine is a very common cause of having fall. Starts in early phase, and it classically presents as anagen. A patient can pull and a bunch of hair comes out.
Yeah.
So that is a very important marker judge that the patient can land up in aplastic. Always check see patient presents with severe hair fall.
Yeah, good point.
Second point was that
See, can I answer this?
Sure.
I mean, when he had a hair fall, we went to NET, and all the drugs were AZA, 5-ASA, steroids, all can cause hair fall. So that's why we send her to dermatologist, doctor, in fact, called Dr. Kalodkar. his opinion. So he said that let us stop 5-USA because, and in fact, in NET also, percentage wise, I think 5-USA leading to fall of hair is more common than ESA.
Second thing, sir, that differentiating between like MV, which we used to read, is more common in patients long standing plus who are on long-term steroids. So steroid is a very important
Yeah.
precursor for having CMV colitis. It
Correct.
was usual in this case. And differentiating between per se steroid refractory ulcerative colitis versus an CMV colitis, because at times, as rightly said, that when the viral load is low in tissue care, because infliximab also manages CMV colitis. So differentiating between UC, which is steroid refractory per se, or this is because of CMV colitis. How to be sure?
Yeah, basically, I think this patient had an established ulcerative colitis as suggested by earlier biopsies and basically CMV. And there are changes. If you see histologically, there is crypt loss, there is a crypt branching, there is cryptitis, inflammatory cell infiltration. CMV inclusions probably are over added. Normally, that I mean, there is no other way than differentiate whether it is a superadded infection or de novo. If you have I don't, what are the changes of, in CMV colitis, histologically, do you get the changes of chronic colitis? I mean, Mike. Whatever changes have been described are chronic
So
colitis changes.
histopathologically, CMV also called scriptitis.
But does it cause crypt branching,
Yes, sir. Yes.
sinus
Because
cell
yeah, it's
metaplasy and all?
severe CMV colitis. The damage to epithelium, crypt hyperplasia appears. Only cases where you already know that there has been a diagnosed case of ulcerative colitis, and now adding C, then we can access. But if you do a primary biopsy and a pathologist, if you ask me, then it's very mimic each history. Steroid always think the activation of.
So I have a comment to make. So in this patient, what has happened is she has had a secondary loss of response to infliximab. After she responded beautifully to infliximab first dose after the first attack being steroid refractory, and later she was doing fine, and then she started losing the response and she started having bloody stools and then had that severe relapse, which made us think of CMV. Now, in the recent updates on IBD, Dr. Ajit Sood sir and his group, they have mentioned that even in the first flare of severe ulcerative colitis, one should check for all the pathogens, because ulcerative colitis is a chronic disease. It builds up over time, and whenever a person presents with a flare, and a severe flare particularly, so you have to see uh, the push that led him to go over the edge, and that could be CMV in the very first attack as well.
Exactly, any
Yeah.
flare.
Right. So he recommends, sir and his group recommends that one should check for CD, Clostridium difficile, and normal stool routine microscopy for bacteriological reasons. Maybe a simple infection such as Shigella or Yersinia, sir said, common, but that can also lead to a first flare of ulcerative colitis and can confuse you with the possibility of infective diarrhea. Second thing is, as you said, so differentiators between CMV being the bystander, innocent bystander, or maybe positive. So in this, there is only one article that has differentiated. There are, if I'm not wrong, there are some 5 to 6 randomized control trials with very small numbers of patients having ASUC, which had CMV positivity. They were not, they were CMV positive, just like this patient. There was no quantitative estimation of the CMV load. So in these CMV positive patients, there are randomized control trials with ganciclovir or maybe just steroids. And these are from the steroid era. And even in the steroid era, there was no significant difference between ganciclovir treated patients and non-treated. Okay, but there was one prospective study. If the CMV count or the CMV viral load is more than 250 copies per gram of biopsy tissue, more than 250 copies. So in that, you will have definite benefit with CMV treatment. Below that, there is no benefit of CMV. This is currently included in the guidelines. So the guidelines say that you should measure quantitative CMV PCR, not just CMV PCR. You do CMV PCR whenever you suspect, oh, she's losing response, or she has had another relapse because I was placing her on some advanced drugs, she's lost relapse, CMV. No, CMV positivity does not mean much, and you will still be confused whether to treat or not. You treat if the copies exceed more than copies per.
Many times we don't have tissue PCR available with us. So
Yeah,
a very rough
that's the
estimate.
problem. In fact, we
a
are
very
done for
rough
the first time.
estimate is that on HNE, if you see less than 5 inclusions, that is a low viral load. You see more than 5 inclusions, that is can be a rough estimate that okay, you for
quantitative becomes difficult and don't have it, then practically you treat every CMV with valganciclovir.
Just make a little comment because used to do IBD research during my thesis was to see infections in IBD and what happens. We looked at different infections. Surprisingly, we're looking at EBV, whether EBV can lead to this, and EBV is ubiquitous. Doesn't lead to this in flare or worsening. What does is C. diff, higher rate of collection, higher escalation. I'm not sure if that's the case with CMV. But then there are several other infections. Of course, in the West, they don't have Campylobacter and Shigella and all that much. But in India, we don't know whether these patients get Salmonella or Shigella, and that leads to the. I don't know if there's data.
So in flares of IBD, Dr. A.S. Puri sir and his group, Gaurav must be aware, and Noor also, they have presented that in flares of ulcerative colitis, you can get pathogens. Get bacterial cultures positive for EBV as well. But then again, like CMV, nobody knows whether they were responsible. Infections are supposed to be responsible. But still, even if you do get stool culture positive or stool routine microscopy positive for, say, E. coli or trophozoites of amoeba, there have been RCTs that if you treat them with metronidazole or if you treat them with antibiotics, there is no benefit. When if you treat them with steroids, then it will be okay.
I just want to share that we've been practicing for the last 40 years, but off and on, I have seen in the recent few years that the presentation of ulcerative colitis presenting like fulminant, like colitis with short history, like infective colitis has increased as compared to earlier. I don't know the reason, but this is just an observation that in the last couple of years, we had seen about 5 to 6 such patients who present with 10 to 12 loose motions like infective diarrhea at to begin with. So that's a change which has been observed. Thank you.
Any inputs from the online chairpersons? Yes, doctor.
Sir, just patient had secondary relapse. In that case, the CMV came positive. So the cause of her relapse was whether secondary loss of response to infliximab or it is just a CMV colitis. So that mere treating the CMV colitis with ganciclovir would have been enough rather than changing or shifting towards tofacitinib from infliximab. And the second is whether why you choose tofacitinib instead of means other options were Vedoli also in this case.
Yeah, in fact, that's a question. What I would say is when there was a loss of response, one of these slides I have said, what are the reasons for non-response? CMV infection, Clostridium difficile infection, these are the reasons for non-response. Now the question is, all these patients, they have a basic underlying ulcer. So when we send the biopsy samples for CMV, it took about 5 or 6 days, and the patient was in hurry to start an alternative. Now, as far as Vedo versus tofacitinib, unless until you have a head-to-head trial, you will not be able to compare. But I have my the intuition from the mind that doing tofacitinib, whatever studies have been presented, have shown a fantastic results, and that's an experience of the other gastroenterologists who have treated these patients. So unless if you have head-to-head trials, then only you can be sure, or either network meta-analysis. Maybe Mohan has some experience because he's working in AG, so he can comment on that.
Well, this also is a very interesting case and a very basic teaching that if somebody is losing response before saying it is exacerbation of ulcerative colitis, one should take a pause, do all the infection screen as has been done, CMV, clostridic, and has been discussed at the length. Tofacitinib definitely is advantageous over below because of the oral drug, easily available. So obviously it scores over Vido in absence of head-to-head comparison. And I think the right decision was made. As logistically it was changed to TOFA, but I would have spent more time in seeing why there is relapse. Is there any super infection? Was eventually picked up, but one has to see full-length colonoscopy maybe to see whether there is any. Obviously, this patient has short history, but sometimes there can be some other problems like super added neoplasias in a long-term disease. Infections definitely is a very important thing which was picked up. I think there's nothing more to add. Everything has been discussed, and this was very well managed case.
Thank you everyone for the interesting action. Let's move on to the next case now. 2 cases of EUS-guided enterostomies by Dr. Saurabh.
Okay, hi, good evening, everyone. Thank you. Yeah, please turn off the lights. Also, these lights. Thank you. So I think we have presented in the previous forums several EUS interventions, and today I think talking about EUS-guided enterostomies, and I have a couple of cases to. Oh, sorry. Okay, a couple of cases to present. Start with the first case, and then we'll there. This is a patient, and this is a 58-year-old gentleman. Had history of CA esophagus from July 2021. Received neoadjuvant chemotherapy. Had a radical surgery in November 2021 with total gastrectomy and esophagojejunostomy. Had postoperative chemotherapy. Surveillance CT in April 2022 and October 2022 showed no recurrence. However, in January 2023, he presented with abdominal pain, vomiting. This is a CT scan actually. Was performed, and I'll show you. See, there are several dilated loops, something that is very evident in this case here. Dilated loops of bowel. This patient, remember, doesn't have the stomach, so he has esophagojejunostomy. And I made a picture to show what actually is this I drew in the evening. This patient had afferent lymph syndrome. This patient, what you see here is the anatomy. This is the esophagus. This is the jejunum, esophagojejunar anastomosis. And this is the jejunal limb, which is the biliopancreatic limb coming from the liver going all the way down. And this was dilated in this case. And I think I may just see again to show that there is dilation of the ducts as well. It's a little not as prominent, but ducts are a little prominent. Okay, so this patient had afferent limb syndrome, and an upper GI endoscopy showed a normal residual esophagus, esophagojejunostomy, with a limited length of one loop leading to a blind end, which is expected. And the jejunostomy site could not be reached as it was further down. If you look at the LFTs, this patient had a bilirubin of 6.7 with a direct fraction of 5.5. OTPT were mildly elevated with alkaline phosphatase up to 220. Albumin was a little low, 2.7, and globulin was 3.1. Now, I unfortunately don't have the MRCP images, but then I illustrated the illustration there, reflecting what was going on in this patient. Dilated jejunal limb, and biliary radicals were mildly prominent, and there was a lot of fluid-filled small bowel loop said. So this patient with afferent limb syndromes tend to have, I'll show you the illustration again. So what happens really is there is sometimes a kink or a twist or a stricture at the anastomotic site that leads to increased pressure in the afferent and further pressure increase in the ducts, which leads to elevation levels, and this patient had jaundice. They also tend to have nausea, vomiting as they had. So let's move forward. And what we decided to do in this particular case, now this patient had surgery, chemotherapy, radiotherapy, and the surgeon who had seen this patient was not inclined towards a surgery of sorts. So they referred to us to see if we can offer a fully invasive option for treatment. So what we decided to perform was a EUS-guided jejunostomy, where we decided to connect the afferent dilated jejunal limb to the standard limb here in the jejunum. This is the illustration showing where the stent was planned, and I'll show you how the case was performed. This is the US scope is inserted, and what we basically do is identify that dilated limb, injected some contrast and blue. Now you can see how the distended limb is nicely visible, and following this, you can confirm that the depth of insertion is adequate. We typically want 4 centimeters. What we do in this case is use the cautery enhanced lumen opposing metal stent, which is called hot axios, available in the market, which basically pierces through with the help of cautery across the jejunal loops. And here we are deploying it across, and what you see on the top right of the screen is the flange. It's a dumbbell shaped stent, and here is the inner flange, which is deployed in the jejunum. So that's what you could see, and there was a lot of bilious contents which were seen coming out following placement of the lumen opposing metal stent. See, this is the endoscope going in, and where the stent. Right, so that's where the stent was. What you can see is this is the stent placed, and you can see a lot of pent up secretions and bile was seen coming out. All right, clean blue to confirm that we are on the correct limb that we injected. This is the anastomes. Post procedure, you can see the CT scan revealing. It's hard for you. There you go. This is the metal stent. This is the limb that was connected to this limb, and therefore this led to decompression. Bile came out, and patient had regression of LFTs with bilirubin of 1.4, OTPT of 39 and 44. But unfortunately, this patient then was doing fine for a couple of days and then still had vomit. Now, just in the tail a little bit, we go inside, and what we realized as we placed a fairly larger stent, about 2 centimeters in diameter. And what was going on was that actually the stent was well placed, but the endoscope was now straight away going inside that stent. Then what we, with some difficulty, we managed to find the distal limb. And what we did was we placed a nasojejunal feeding tube in the path where the actual food go. Because now the food was going through this, although the bile and secretions came back, but the food was now going in the wrong direction. So therefore, we put a nasojejunal feeding tube, convince the patient to wait. He did well, was getting nasojejunal feeding. No jaundice, no nausea, vomiting. And after some time, this was removed. And fortunately for us, this was my first case. It was a EUS-guided jejunal anastomosis that was performed. Another case here, it's a 73-year-old gentleman, history of diabetes, hypertension, coronary artery disease, status post PTC in 2016. We have presented this case for those who attended the prior meetings, and for those who did not, this is a quick synopsis. This patient had a very interesting story and course, and I think what I am most impressed by is the fact that he decided to continue to stick with us in today's day and age of doctor shopping, where a patient is seen trying to see 20 doctors. So he starts his story back in 1995 from when he had recurrent peptic ulcers. He had distal gastrectomy with gastrojejunectomy, with a vagotomy in 2002. Eventually had recurrent ulcers and developed Roux-en-Y and gastrostomy, Roux-en-Y and gastrojejunectomy in September 2015. A redo surgery, now he has 2 surgeries. Then he had some esophageal tear apparently and requiring hemoclips. Then he had this very difficult ulcer, which was in June and July 2022. And this is a fairly short synopsis of the case, but this patient had a very, very nasty and a very difficult ulcer-related bleeding. He had recurrent GI bleeding, which was very, very difficult to manage. And ultimately, adrenaline, various injections, and ultimately what we ended up having to do was to put an OTSC clip, and that really actually beautifully, and his bleeding stopped. So this is the patient who had 2 surgeries in the GI tract, had recurrent ulcer bleeding from just beyond the gastrojejunal anastomosis, requiring placement of the OTSC, and then control of bleeding. But here's the problem. Now you have managed to do that very well. His bleeding is stopped finally, and no third surgery, fourth surgery required. And when we put the endoscope, I'll just illustrate what things are going on here. This patient has a lot of food in the stomach, as you can see. He had large volume bilious emesis, and this is the site where the bleeding was. And as the endoscope is advanced, we place this clip successfully, but here's the problem. Now the clip with all that invaginated tissue was now making our life very difficult because the food is not going, because that clip has pulled in the tissue, and now we have created an iatrogenic problem here of gastric outlet obstruction to control this bleed. Of course, this had several surgeries, so surgery was not a desirable option. So I said, okay, maybe it's edema from the clip placement. Why not give him a chance? We placed a nasojejunal feeding tube for 8 weeks and said, let's see, maybe the edema will settle. I pull out the tube and he'll start eating. But unfortunately, the problem was we removed the NJ tube, but then he developed recurrent symptoms of vomiting post feeding tube. So now with that, with several surgeries, all these limbs connected in different ways, we ultimately decided to do a standard EUS-guided gastrojejunectomy. And this is the stomach. And what I wanted to really do was with the prior surgeries not have any issues. So we decided to find just the limb distal to that obstruction of secondary to the clip. And here is directly the percent again. So this, again, same style that we did last time, jejunal anastomosis. Here we managed to get access just distal to it. I'm going to, and if I, this is the jejunal limb. This is just 3 centimeters below the clip we found. And we got a nice window there. It's a nice depth of insertion. And similarly, what we showed you was a artery enhanced stent, which we placed again. Now here is the clip. You see, this is the clip. You see just about 3 centimeters below, we found that access point. Managed to get a stent. The This is it. So the clip, and then this is the stent. So we did a quick bypass, right? Again, so the patient did well, no symptoms of gastric outlet obstruction, and is happy. That's what we did. So just for some people in the audience who are not familiar with this, which is the endoscopic ultrasound guided gastrojejunostomy. This is a newer therapy that that's available with the help of EUS, where the anastomosis can be performed in various ways. And these are illustrations of GJ, but you can do, as I showed you, GJ, you can do colocolonic anastomosis and various anastomosis depending on the need of the patient. These were patients who were probably deserving ways of minimally invasive approach because they had 2-3 surgeries, both of them. The surgeons were reluctant to perform a surgical intervention. So this is there are various techniques employed, but what we are doing in now, because of lack of the right options, is direct puncture approach, which is illustrated in the figure on the left in A, where the axis is directly punctured. The problem with this is that can be a risk of complications when it's not done correctly. The bowel moves, and we have had our share of issues before. So that's something to be very careful of. The other techniques, there's an EPAS balloon, which Dr. Ramchandani, I'm sure, has experience with as it's under experiment. But this can make it safer, and most of the live demonstrations in the country are done with this particular balloon, which is not available in the market, unfortunately. But now we are left to freehand techniques. So just a few notes. This is a meta-analysis looking at EUS-guided gastroenterostomy of 285 patients. You're looking at a technical success rate of 92%, 90% clinical success rate, and adverse events up to 10 to 12%, and especially earlier in the learning curve. Again, I'm not here to judge and decide which procedure is better, but these are some potentially biased studies, in my opinion, of retrospective analysis of EUS-guided gastrojejunostomy versus surgical gastrojejunostomy. And what you see is there's a similar clinical success rate, 87% versus 90%. Adverse event rates was not the arms. And this was another study comparing EUS-GJ versus laparoscopic GJ. In this particular study, again, similar technical and clinical success, but adverse events rates were lower in the left side EUS-GJ arm. And just to illustrate the point, what we did was jejunostomy. Now it's being described in literature. This is a series of 4 patients where you can see jejunostomy, and these are being done for afferent limb syndrome patients with a pretty good success rate in terms of and clinical success rate. Thank you. I'm happy to take any questions. On the lights, please.
Thank you, Dr. Saurabh, for the excellent presentation. Any questions from the audience?
Yes, yes. Right, yes. No, what was meant was when the endoscope was advanced, we use a standard endoscopes. Standard endoscope could not reach the site of the anastomosis, basically. As far as the correct, the esophago-jejunal, of course, can be seen, but jejunal anastomosis cannot be reached with a standard endoscope. One option is that you can go ahead and use double balloon endoscopes, enteroscopes, to go further deep down, find that, perhaps make an angle your way up there. But in this particular case, it was evident that that was the site of obstruction, basically with dilated. With the EUS scope, again, you don't have to reach the anastomosis, because what you're basically creating and identifying is the dilated limb. Once you identify the dilated limb, you can basically go ahead and create the anastomosis. In the second case, you mean to say the GJ, post-ulcer bleed OTSC? Dilate, you mean, I'm not sure if I follow you. Oh, yeah. So, correct. So, no, yeah. So, what you have to do in those cases, I think we skipped through some of the actual technical issues, is here in this particular case, the scope could be advanced. So, we put a guide wire We put a nasal tube in the jejunum, and what we do is fill in a lot of water. In the first case, that was not required, but access, now that's a different technical issue. Second case, the endoscope did go with twists and turns through. Put a guide wire, put a nasal tube, a 7 French catheter. Then we put a lot of fluid from that nasal tube. That distends the lumen. Then we put the GJ. Yeah. Enteral stent could have been done. Yes, but the problem is in a benign case, putting an uncovered enteral stent would not be generally advisable because it's an uncovered stent. Malignant, yes. The first case, that's a little different because there was a dilated limb and access to that limb was not possible with a nasal tube. So what we do is we put a FNA needle, put in a lot of fluid, distend it, and then do the anastomy. So technique is different in the two cases.
Saurabh, congratulations, the wonderful cases. Just want to know for how much duration will you like to keep this? Because these are the benign cases.
Yeah.
the cases.
Oh, true. I think both cases, I mean, that was a malignancy and that recurrence. I suppose you can take out the metal stent, can be removed, but there have been a lot of reports now with gastric outlet obstruction, benign peptic ulcer related disease or chronic pancreatitis where they've been performed and patients are doing 3 and 4 and 5 years after this, doing absolutely fine. So with those reports and those experiences, I'm inclined towards keeping the stent in both the cases. Definitely in the second one, because you remove it, he has obstruction again, then we are back to square one. I don't think it's a choice in the second one. The first one, you can remove it. The fistula is there. You put a plastic tube or something like a stent. But I suppose with the primary pathology, you may develop issues again. If the stent, if you put a plastic stent, double pigtail, it migrates, then you can have the same problem again if that fistula closes. So I'm inclined towards keeping them long term. Yeah.
Can be an option.
Right. I think certainly worth a try. You can go in, you can go deep, go and reach the site. Certainly worth debatable whether we should have gone there at the site to identify. Perhaps make our way into the afferent limb and see what we can do. I'm not sure if it would have served a major therapeutic purpose because the primary issue, whether it's denervation or twist or whatever is the reason for afferent limb syndrome, would have persisted. And I think it would not have been a solution, rather. It would have been more, I mean, I think we would have learned something more. But I think what I've seen in these cases is sometimes a sharp angle. That could be true. Pinking, acute angulation, unlikely to be a stricture. Maybe denervation, yes, that's been said. Essentially, surgeons will be able to
Dr.
guide.
Saurabh, what was the
Yes.
what was the further course of management after you put the NJ? Because still the stent was blocking and the contents of the
Right.
afferent limb were coming in the jejunum.
No, I think, see, somehow body does tend to manage its way to get the food in the right direction. We have done so many places, EUS gallbladders and EUS-Guided colostomy and all of these, and I always think, intuitively you think that all the food is going to go inside the bile duct and the gallbladder. It just never happens. Somehow the food just goes in the right direction. In this particular case, the guy was vomiting, we put it and then going fine. So somehow, I don't know how it works. Peristalsis works in the right manner and the food, despite our belief that it seems.
Sir Mohan Ramchandran.
I think, Saurabh, can you hear me?
Yes, yes, we can hear you. Thank you.
Okay, so it was fun. Both the cases were excellent. The first case where you did a jejunostomy, the technically challenging because you have to go through the narrow conduit with a EUS-guided scope. The discussion regarding going into the jejunal anastomosis versus the jejunal enterostomy, the pros and cons are if you are going through to the jejunal anastomosis, you will require a long scope, maybe a single balloon or a double balloon enteroscope. The challenging part is to reach over there and then putting a plastic stent over there. Majority of the time, it is the kink or the angulation which causes. But in a case who has already a malignant disease, there can be a recurrence. I would have done a PET scan to see whether there is a recurrence, or sometimes if you can reach to the anastomosis, we have done many cases with GJ, gastrojejunostomy, and presenting as afferent loop syndrome with obstructive jaundice because of the back pressure. And out of 6, maybe 2 were recurrences, which were picked up by the endoscopy because we can go into the afferent loop. Here, we did not go into the afferent loop, so etiology was not established by the luminal. However, CT scan was done, and subsequently it turned out to be a benign disease also. But one can do some investigations to rule out recurrence because in a malignant disease there can be recurrences or there can be multi-level obstructions. That is one. Otherwise, this case is technically challenging because one can perforate the jejunum if somebody is going deep into the jejunal limb and doing jejunostomy. That is really a technical and very well done, Saurabh. The second case was also absolutely fantastically managed. Iatrogenic jejunal gastric outlet obstruction created because of control of the bleed and then led to obstruction over there, and then then GJ was done. Also, in absence of EPAS balloon. EPAS balloon, what it does is it creates an pseudocyst like an environment. It fixes the bowel. So the chance of misfiring or chance of going into colon is minimized. While if you're doing freehand technique, there is lot of chances that your jejunal loop may go away from you once you are puncturing, and it is always not a foolproof technique. It's the rewarding technique, but a lot of work has to be done to make it foolproof, especially the freehand technique. We have created a lot of problems. Many times before we zero down to the EPAS balloon, though Boston Scientific is now working on it to be commercially available. Guys from Kerala, Cochin, they are also have made a good balloon. So balloon makes the bowel fixed to the stomach, and it's like draining a pseudocyst. While freehand, you either have to put a 10 French NBT or a balloon to inflate the bowel with a lot of saline and methylene blue, but still, in most experienced hand, it can happen that your stent may be deployed in peritoneum and you have to call your surgeon. But these 2 cases were very well managed. I think in benign disease also we have seen the role of axial stent, chronic pancreatitis, groove pancreatitis. These patients have portal vein thrombosis, splenic vein thrombosis, leading to extensive collateralization. And these patients are not good candidate for surgery also. Such cases, you can put axial stent, and we have patients of around 4 to 5 years. We keep on exchanging them. We call them after 1.5 years, remove the axial stent and put. They are so happy that the surgery is not possible. It's a benign disease, but they keep on exchanging and they gain weight. The gastric outlet obstruction is gone. So it's a very rewarding procedure, but still very not 100% foolproof. But there are ways to make it more safer.
Thank you.
Thank
Thank you
you.
so much for the comment. Just to reiterate, I think the PET CT was negative in that patient. But yes, a point well taken. I think what we are planning we should do is go ahead with the endoscopy and get the scope till the site of obstruction and then reevaluate it with endoscopy also. I think that's something we will certainly be doing.
Any questions
other
from the
questions?
audience? We'll
Thank
move to
you.
the next case, which is a pancreatic head mass with abdominal
Should you-
lymph nodes by Dr. Saurabh.
Maybe Bhushan, if you want to do your next case, that's okay, and then I can do the last one. So it's a small case, mine, but
Welcome, Dr. Bhushan. Big gastric ulcer with recurrent bleed.
All chairperson audience. Hello, Mohan sir. Hope you remember. Yes, sir. Hello. Yeah. This is one of the interesting case of a very severe upper GIB recently we encountered. She's a 75-year-old female with no comorbidities, presented with a very hematemesis and melena of very large volume, so much so that she has to hospitalize in ICU and required multiple blood transfusion. He was admitted like multiple times. He was recently admitted for around 15 days in ICU, where the hemoglobin was dropped to 4.6 gram per deciliter because of hematemesis and melena, with the rest of the investigations appear normal. In the desired hospitalization, he was and she underwent, she was given 8-time blood transfusion, and OGD was performed twice a times. And this was an OGD report where endoscopist, he went to a gastroenterologist, and the endoscopist has reported there is a very big gastric ulcer on the lesser curvature, which was morely he labeled as a very large clean base ulcer with a everted margin. And to his eyes, it appears to be a very malignant, and he took a biopsy from the ulcer, and there was no any stigma of recent bleed, and he didn't do any endotherapy for the particular lesion. The biopsy specimen comes to be more about an H. pylori related gastric ulcer. There is no evidence of any malignancy given in the report. So during that hospitalization, when where partly the bleeding was partly controlled or not controlled, second episode happened in the hospitalized. Again, patient has to be shifted from ward to an ICU as per the paper reports. And endoscopy was again performed, and more about reported the same ulcer. And this time, I think so, he also didn't do any sort of any endotherapy. He looks that there is no any stigma of recent bleed. It was just an ulcer which is bleeding. And again, the patient was just doing an endoscopy and was managed conservatively. Bleeding stopped during that hospitalization, and patient was discharged. Then again, patient had second admission, again with a third episode of hematemesis, again had a severe GI bleed, again required blood transfusion, and this time the endoscopist has done an endoscopy which showing he labeled that there was some stigma of recent bleed. He had injected an local adrenaline therapy for that large ulcer. And subsequently, the bleeding stopped during the hospitalization. The patient was discharged again. Third time, patient had a bleeding. Patient went to same gastroenterologist. Again had a blood transfusion. This time the patient has done a proper had advised to go CT abdomen angio, and there was no any extraction of the bleeding vessel or any aneurysm noted, but there was reported there is a focal enhancement, thickening along the lesser curvature with the transmural involvement and fat stranding. And finally, patient came to Midas with these 4 major episodes of bleeding, and in the past requiring 12 PCV transfusion with persistent melena, tachycardia, conscious oriented. Patient has a severe pallor and per abdomen was soft. So as you can see, the hemoglobin still was 5.6. We managed in the ICU. We given a 2 PCV transfusion, started on PPI infusion, and OGD was performed. Yes. So as I go inside, I see there is definitely a large clot which was seen in the stomach. I entirely check. I was able to see the ulcer which was on the lesser curvature. I just make sure that any duodenum D1, D2 everything was normal. I didn't do any active ulcerations or any signs of any hemosuccus or any other pathology other than that gastric ulcer. So I can see there is a very large ulcer with a definitely a clot sitting above it. Yes, I did. Just you can see there was a clot or maybe a tissue. I was partly. So I injected an adrenaline over it, just at a base, and I just want to remove the clot or tissue to make sure that whatever therapy what I was applying. Definitely. Once I removed that clot, you can see it was like a pulsatile ulcer with pulsatile bleeding which was going through it. So I just decided we should do a best therapy. What we have is do an OTSC clip. It was very difficult to get an end-on view for that ulcer because of an ulcer which is coming on lesser curvature. So I took a quite time before placing because it may get a misfire. So I properly sucked it this time, get an end-on view, and properly you can see the ulcer is coming inside. And finally, I deployed the clip. Once I deployed the clip, you can see it was very nicely placed. You can see the ulcer has completely been under the OTSC clip. And yes, post procedure, we continued to PPI infusion for 72 hours. Patient vitally was stable. Patient was discharged on day 5. Yes, these OTSC clips are more effective than the standard endoscopic therapy for the patient of recurrent peptic ulcer bleeding. It was a sting study which has showed that if a patient having a refractory bleeding just failed to endoscopic therapy, this OTSC clip has reduced the risk of further rebleeding. As you can see, just 15% as compared to the again endoscopy of 57.6%. But now the same group of person, now they are endorsing that rather than waiting for a refractory GI bleed to be happened and prolonged hospitalization, why not we endorse as a primary modality of a treatment as seen in this Stings 2 study. But the selection of patients should be very, not like every patient should be going for OTSC because that requires some expertise. It is an expensive OTSC clip to be happened. So if a patient having a high stigma of bleeding, that if having an if having an active spurter or having a non-visible vessel, non-bleeding visible vessel, this OTSC clips is performing as we can see a much better than the standard hemoclips or a MPEG or a coagulation what we have performed. It has also been come in randomized control trial where they have found that OTSC clips as the initial management may be better than the standard treatment in reducing the risk for further rebleeding from a non-varicose GI bleeding. Thank you. Sir, for first place, like outside? Just asking. Yeah, sir. Absolutely, sir. I think this is, we are talking a decade back now. If you are going to a gastroenterologist, the first thing, yeah, you're right, like, yeah, first refractory bleeding, but the therapy was not adequate enough to that he will earn a surgery. Yeah, he had just given an injection adrenaline and just proven that it is not bleeding. So that's why we went inside. We did a better therapy in the form of dual modality of treatment in the adrenaline and use the best clip. The patient has survived from a surgery. Yeah.
Bhushan,
Yeah. Maybe, sir, if I don't know. Absolutely.
actually, when the patient presents, you don't know that she is going to bleed 3 times more. So, after this presentation of 4 time bleed, you are retrospectively saying that the surgery. So, but then, that could not have been done. So, one would like to always try and salvage by a minimal resume.
At the end, we want to do a minimal anyway, but you are completely agree, sir. Why not do a surgery in this thing? But we do a best therapy and wait for the best therapy. The patient also agrees, okay, and do a one more time to an endoscopist. We'll do best.
And we are running out of time. Yeah. Next space is, sir, we move on to the next case by Dr. Saurabh Mukewar, pancreatic head mass with intra-abdominal lymph.
Request hotel boss. Did you turn off all the lights here? Okay, so I know we are all few minutes away from drinks and dinner, so I'll be brief and quick. I think okay. We switch to the okay. Okay. I'll start this case so that the 52-year-old male presented with dull abdominal pain for last 2 months. Patient had a low-grade fever, anorexia, weight loss of about 8 kilograms in a span of 2 months. Ultrasound revealed a retroperitoneal lymph node mass with liver lesion. I'll show you a CT scan here. Looking at the CT scan, whereas well is not, well, there is not here. This is a mass in the pancreas. You see there? Mass in the pancreas. Some lymph nodes. So Well, we decided to go ahead with our standard. This case, we went ahead, found several lymph nodes in this patient. See, that's one subcranial lymph node in the mediastinum, iliac lymph node, then the mass in the pancreas, which you see, the hypoechoic, which means darker in appearance, and irregular margins. So seems like a routine patient. We said, okay, let's go ahead with the mass biopsy. And we are using a 22 gauge fine needle biopsy to obtain sample from this lesion. It's obtained. And I think the patient ended up not sending the sample, or some technical issue happened for him. And he had persistent symptoms, of course. And our sonographer had initially not been able to get access to the mass, but we said, let's try again. And then they got a FNA from the liver. And so we had basically two samples. Now this sample is under process, and then another sample is obtained from the liver. And what basically my conversation with the patient and the family was, boss, I'm seeing subcranial lymph nodes, I'm seeing mass in the liver, head of pancreas mass. It all looks malignant, and I practically gave him a death sentence that I said, have a few weeks to live, they'll confirm. And this is what happens routinely for us, most of us who do this, we see patients. Looks like malignancy, we got it. Here's a surprise. So not a surprise, like, well, this patient actually had tuberculosis. So while we have presented a previous case of pancreatic mass presenting as TB, but I thought this particular case was fairly eye-opening, because I would not have imagined at all this patient actually has TB. So his TB was not only involving the pancreas, but had spots in the liver and then the subcranial nodes. Everything to me had looked completely tested malignancy. But this patient had on both samples convincing evidence to show tuberculosis. So it's not that there's some sampling error here and there. And the reason I'm sort of bringing it up, I think, was because it was some sort of an eye-opener for me. And just to illustrate the point, it's a very short case, that what you think you see is not what is always there. And there's a good reason why our oncologists always want us to get samples, because and confirm before they give chemotherapy. Because I know from the surgery colleagues who are not very familiar with the endosonography options would probably have taken the patient for Whipple's had there not been a liver lesion or lymph nodes. So again, this is a unique diagnosis found. And our oncologist would want tissue for a good reason, because this guy has tuberculosis, and therefore a tissue is the issue and should be taken. So I won't have any more discussions. I just thought very interesting finding that we experienced to illustrate the point of and the advantage and the reasons to take samples when required. So happy to take any questions. Yeah, negative. I don't remember. I don't think so. I think let's see whether diabetes was there or not. Probably not. Let's see his history. True. But I think we have seen patients have tuberculosis in the abdomen. No, he did not have diabetes, steroids. And we have, we see GI tuberculosis all the time without any immunocompetent. So this happens to.
So was there a head mass at all, or everything was lymph nodes and something in the liver?
No, it was a.
And the biopsy came positive from the liver?
Both. Positive in tuberculosis in both. I think, sorry, I apologize, Dr. Pandey, if you can some comments. I got you here, sorry. Maybe I'll pull up the slides so that you can some comments.
Pancreatic tissue along with granuloma. Aortic.
Can you switch to the?
No surprise.
Nothing,
on the
no surprise.
side, yeah.
There's absolutely no doubt about it. Yeah. And I think we can evidently see the
This
granuloma
is the
there.
second case of pancreatic tuberculosis.
No, I
Yes,
think about 4 cases, 3 or 4 cases.
Nice case, Dr. Saurabh. I
Yes,
think
yes.
there was a pretty much amount of right-sided pleural effusion. So what about like diagnostic tap from a pleural
Yeah, I
effusion?
think I have to see. Which was the vision, but sometimes a little bit of pleural, and there is what we end up seeing now. In retrospect, we can always go back and see.
So
Could have picked
Dr.
up TB
Sagar
then.
online, he wants to ask. I
Sure,
think.
yes, yes.
There are tumor markers, whether it was raised, CA99 or some.
Oh, good point. I think what happened was this patient presented with these findings for the biopsy essentially, and then biopsy was performed, and I think that point we were waiting for the biopsy. This is metastatic disease, not obtain tumor markers, but typically we generally yes we do obtain tumor markers. We just ended up the biopsy at the first go did not get the tumor. I think would have been probably beneficial to see if they were high or not. Good point.
What are the radiological differences between benign or a tuberculous mass and a malignant head of lung? What differences would you expect in an EUS?
Yeah, so I think we'll have to see. We don't have experience with patient pancreas to tell you the actual differences. Asiatic material coming out go in favor of tuberculosis, and we have seen that happen in the first case we did, where there was a clear whitish material coming out that time. The consistency on biopsy that you perform, your biopsies and the tactile sense, whoever does recognize that tactile sensation is of good importance because you recognize that a tuberculosis is never hard. Mass malignancy, you have to go through a rock. Tuberculosis, it's softer. That's the second thing.
Did he have jaundice?
He did not have jaundice.
That's another hint. Head mass sitting
True.
really at a strategic location, but not causing jaundice.
Fair enough. I think yes, his bile duct escaped. I think, and radiologist we don't know, madam, but I think the radiologist impression was malignant with metastatic deposits. That was the impression.
By Dr. Mohan, sir.
Yeah, yeah.
I think two last cases we saw, Bhushan's case, large gastric ulcer. He showed some data that OTSC, and but a recent randomized control trial, which is the highest degree of evidence published in Gut from Prince of Wales. They have clearly shown that OTSC may not be that rosy picture. In fact, the rebleeding rate at 30 days were equal in the standard arm versus the OTSC arm in a peptic ulcer more than 1.5 centimeter. But the case was very nicely managed. I think we should also take gastric ulcers very seriously, try to establish etiology, because in gastric ulcers, one cannot, very complacently say that it's peptic ulcer. We should spend time to see serum gastrin, see good CT, take a good history of NSAIDs, H. pylori. Multiple biopsy being negative can still be cancer. So if a non-healing ulcer is there, it's not only to control bleed, but also to establish etiology. We have burnt our finger being happy about controlling the bleed, but patient coming back with metastatic disease. So unless you are very happy, very patient, being followed up very closely, that ulcer is healing, ulcer is gone completely, then it's okay. Otherwise, one can err on the side of surgery in a gastric ulcer. Regarding Saurabh's case, at the moment I saw the CT, I did not see any pancreatic ductal dilatation. In a patient of ductal adenocarcinoma, one has to have a pancreatic ductal dilatation. We have seen many retroperitoneal node cannot be separated by pancreatic head, and the node which is in the liver, in fact, is a periportal lymph node. So it is quite possible that there is a big lymph node very adjacent to pancreatic head, not separable. The patient had a necrotic type of lymph node. So possibility is there that it's a retroperitoneal node, not a mass, but it's very difficult to differentiate. But ultimately, I think diagnosis is made, and one has to see a very good CT scan. It's not like a CT scan with pancreatic protocol. must see how the contrast is going. You can differentiate a neuroendocrine tumor, you can differentiate pancreatic lymph nodes, you can differentiate pancreatic head mass by seeing how the contrast is traveling through this mass. Just mere saying that radiologist has said malignant, but why malignant? Is there any hypoechoic mass? Is there any a mass which is not enhancing? There are many other features, pancreatic duct, what is happening to pancreatic duct. Before jumping on to the more advanced technique, one should spend time. Even for the resident, I will say that go to the radiologist, see the scrolling, see the strain, what is the arterial phase, what is the late arterial phase, what is happening in the portal venous phase, then come to a conclusion. So you will zero down to many diagnoses before jumping on. See, saying a patient a cancer, it's like it's like curtain for them. It's devastating for the family. So it has to be very, very a thorough imaging study. Then only jump on to the. We have seen xanthogranulomatous polycystitis in CAGB, saying patient, oh, this is cancer and you cannot be doing. Some patients have committed suicide also. We have heard about that. So better to have a good histological diagnosis, proper contrast study, and then revealing the patient. But this is a very, very important case, a relearning case. Completely, I think it's like autoimmune pancreatitis. We have seen patients who are declared cancer, but coming back to us with autoimmune pancreatitis. You have to see the duct size, whether the duct is sclerosing, there is other organ involvement like kidneys, like salivary glands. So you can differentiate mass by proper imaging. So my take-home message would be, don't jump on just one plain CT or a contrast CT. See a good contrast CT, spend time with radiologists, and then come back to the final diagnosis.
Thank you. I think that's a very valid and important point. Just to revalidate, tell you that I think the retroperitoneal masses cannot be clearly distinguished from the uncinate process of pancreas. So unfortunately, that is a very hard thing to get for most radiologists also. The lymph node, or is it a retro mass from the uncinate pancreas, can be one, hard to say. This patient actually had liver as well. It was not actually, I don't know, just to clarify that. So therefore, I think for those two reasons, but I think very good point that the CBD was not dilated and the pancreatic duct was not dilated. I think that is a very valid point, that uncinate masses would typically invariably would have led to some degree of dilation of the pancreatic duct, and certainly a double duct sign would obviously be very obvious. That's certainly the case. And I think autoimmune pancreatitis was a little bit of a less chance for us because of the way the mass was, but yes, I think surprises are always there. Yes.
So it seems we are seeing this type of pancreatic, so-called pancreatic tuberculosis quite often. In last 4 years,
Yeah.
between you and our center, we must have seen about 6 or 7 cases. So my question is, given the discussion by Mohan and what you are also saying is able to differentiate between the head of pancreas and the lymph nodes.
Yeah.
So does the literature say that there is primary pancreatic tuberculosis exists, or it's always confused with the lymph nodes surrounding?
No, I think very valid point. Say it's pancreatic, but then it's lymph node, and it's just there's a way to differentiate between this and that. There is evidence in literature to support primary pancreatic tuberculosis. That is there, and whether mislabeled means. In this particular case, again, to our eyes, it seemed like uncinate process. There was a lymph node in that uncinate vicinity right there. We don't know. Hard to tell.
Actually, the lymph node, it
Must be the one.
invades the starting is the lymph node. Then
Yeah.
Histologically, if you can have a pancreatic tissue, either with granuloma probably, that is okay. But I mean, there are cases of primary pancreatic tuberculosis described in the literature.
No, absolutely.
The case, primary pancreatic tuberculosis does exist because not just the head, there is not just the involvement of head. We have seen mass forming regions involving the body and tail region also. And when you take a FNA from that, it turns out to be TB. Thank you. A nice demonstration.
Thank you.
Any
Thank
further
you.
questions? Thank you.
A nice clinical meeting. We have learned quite a bit in all the 4 cases. So I really thanks my all chairperson, Dr. Manoj Vivare sir, Dr. Saurabh Patle sir, Dr. Gaurav Padia, Dr. Prachi Mahajan sir, and also my online chairperson, the respected Dr. Mohan Ramchandani sir, and also an upcoming gastroenterologist from Yavatmal, Dr. Sagar Bothra. So really, we also thank Team Abbott for successfully conducting this meet, and we all welcome for a nice cocktail and dinners available. Thanks. Yeah, sir. Gedam sir, thank you for all sharing this. All fun.